Everybody, but I know that we've got some attendees.
The broadcast is now starting. All attendees are in listen-only mode.
Hi everybody, my name's Alison Foster, and I can see that there are some people on already. Sometimes it can take a few minutes just for people to log in, and I know we've got quite a few people logging in today, so I just want to give people an extra couple of minutes. I know frustrating for those who've managed to log in on time, but just that extra couple of minutes might just give people who are using this technology for the first time a bit of time to log in. So I'll just hang on a couple of minutes. Thank you. I should have had some music in the background organised, but perhaps that might be a bit more annoying for people. Okay, I think what I'm going to do is I'm going to start, and this is being recorded, so if there are people who come along a little bit later and miss some of it, hopefully we can send it out once we get it uploaded. So just to say again, I'm Alison Foster, and Matthew Barrington is also on mute at the moment, so there's no additional background noise. And just to explain a little bit about what we'll do today, on your screen, I don't know where people have got the control panel on their screens, but hopefully you'll see an area that says chat on it. And if you click on there, you should be able to type in any questions that you might have as you go through the presentation on there. And what we'll try and do is, if there's something really pertinent as we are talking, then I will endeavour to try and respond to them, but ordinarily we'll come to those right at the end and try to address any questions people have at the end of the session. Okay, so firstly I just wanted to say a little bit about how we're going to do the presentation, and let's click on here, that's it. And today what we're going to do is I'm going to talk a little bit about some of the context about who we are in Pi Care and Health, what we do, who works with us, and what's the big deal about this tool, because that's the other thing that people are wondering, why is this so important, and what is it that it can achieve. And obviously I would say that it's a fantastic tool because I work for the company, but I've worked as a nurse for quite a few years, and I've worked in commissioning, and this type of technology really speeds things up in terms of the ability to analyse multiple data sets, so just in terms of time of developing some reports and analysis, and the ability of it to display it in such a way that it can really help you identify areas for improvement. So I've been a fan of this tool for a number of years now, and I hope that by the end of it you'll see why. Our demo will show you a little bit later on, and Matt, our business analyst, will talk you through how you can view things like your demographics, what services are accessed and when, what patterns and variants can be seen through doing it in this way, the opportunities for some improvement, that have been identified, and a number of our clients have identified areas for improvement and are tracking those through. So obviously you want to be able to see if some of the service improvements you make are making any difference, not just in the service, but are they making a difference across the system? Are they making a difference to an individual's care pathway? So is the way that you're delivering an intervention going to help their entire contact with not just health services, but social services and other supporting services? So the benefits of a whole pathway view, hopefully you'll be able to see by the time we go through this presentation. And we're going to talk a little bit about risk stratification. That's probably a whole session on itself, and predictive modelling, but just to let you know the power and benefits that this tool can bring to that area in particular in this service improvement. So Pi Care and Health have got quite a track record going back 30 years where we started as Pi benchmarking. And in the last 4 years in particular has seen significant growth. So we've had lots and lots of, particularly in care and health, we've had lots of systems, and I'll flip to our customers in a second, but we've had lots of whole systems join up and use this tool. So that's health, care, ambulance, 111. We'll go through all of that as we go through. So that's really helped us in care and health to rapidly expand our service and to develop the product as a result of what clients are telling us that they need. So it gives it pulls data in from different silos, from different organisations. So we all know we've got secondary use data that we can get, and we've got data in social care. And what it does is it connects those data sets through at the moment using NHS number, and then it can integrate them and show a whole pathway view. The benefits to some of this is looking at things, and it's the type of activity is cost and activity data and demographics. So looking at before and after costs of an event, or before and after activity for an event, such as a fall. But the event could also be an intervention, so a falls prevention service. So you've identified that there are a group of people having falls. You then implement a service, and you can track what happens before and after that service has been implemented. We do lots on risk stratification, as I've already outlined. And the flexibility to create your own analysis depending on your current issues. So hopefully when you see the demonstration, you'll see how the tool is used. So it's something we help you to use yourself, and it's very easy to use. If you can navigate your way around an Excel spreadsheet, sheets, not even formulas, you'll easily get to grips with what this can do to support you. So it's really flexible, so that actually we all know that this month, next month, there are some areas that are very topical. So we know sustainability and transformation plans are very topical at the moment. They've got to be in by the end of June. In other times, it might be quick plans that you're working on, so in an NHS organisation, or it might be better care fund plans that you're working on across both social care and in health. So depending on what it is that you're looking at, it's really flexible. Once we have all the data in, it's the way in which you look at it, it will be entirely up to you according to what you need to look at. The other benefit of this tool is that it's deployed really quickly, and I'm yet to come across a tool that has this ability to develop to deliver it really quickly. And I think that's because we've been doing this for probably 7 or 8 years now in care and health, and we've got a team of people who have been with us almost all of that time, well sort of versed in developing it and delivering it very, very quickly. So I think that's something quite unique to what we do. We have a mix of public and private sector customers or clients. So we've got people in procurement, in travel, and in other areas where benchmarking is used, and that we benefit from that. We benefit from learning from what private sector organisations do and use, and in some areas they have a really good ability to show us what real-time data is. So we've got clients who, such as a pub chain, who use this tool and they refresh it daily. Now in care and health we're only being asked to do that monthly, but it's completely possible to do things daily. So we're learning lots of things from other sectors that we bring into the development. And on the development, 40% of our profit is completely reinvested into research and development, which I think is a unique part of what Care & Health have. Just a very quick glimpse of some of the customers that we work with. That's not all of them, but to let you know that we work across health, social care, private sector organisations, and national organisations. And so today it's just really, because this slide is just to put you in the mind of there are many factors, as we all know, that affect health outcomes, and there are lots of opportunities for both individual improvement and system improvement, lots of data available to us. So we know that things like your age, gender, ethnicity affect that. We know about life and how they affect your health outcomes, where you live, how your access to services, levels of deprivation and inequality, your childhood experiences. Those things are really all contribute to health outcomes. But what we're going to be looking at today is how we use the individual data sets, so your gender, age, where your GP practice is, so that's something about your access to services and who provides that service. The activity, so what do you do in terms of interacting with those services? So what services are you using, where are they, when do you use them, why are you using them? So that can be identified through looking at some of this data, and who are you interacting with. So some of the workforce data, for example, is really important when looking at how you access services. And then we link those across to the cost. Every activity has a cost related to it, and we put those through and connect them through the NHS number. And we can do it at an individual level, and Matt will show you that on a demonstration. So we can see at a really granular level each activity, where it was, when it was, who you interacted with. And then we can aggregate that up to population. So across the system, and we're looking today at how this might support sustainability and transformation plans, it's looking at cohorts of people who are at high risk of accessing or accessing emergency admission, or people at high risk of having a fall or having a stroke, those kind of areas where we want to really help people's outcomes to improve, and that's what we do this for. So we are looking at population level data, so we take them in cohorts or in groups. So again, it's just here that we've got age, gender, demographic information, which I think when you have a look at it, you'll see that it's displayed in a way that's so easy to interrogate when you've got this in front of you. And I've worked in clinical commissioning group, view can be quite difficult. So we're looking at the and having help you identify areas for improvement and transformation and how through helping improve health outcomes. One of the other areas that we can what we generally are dealing with is the data outlined, but of course if there are other data sets out there that we can link in, that is completely doable. And there are some council areas that are looking at data, for example housing data, which we started to do in some areas ourselves, but housing, access to job centres, children's centres data. So there are some really innovative things about pulling in that wide data set that's happening throughout the country that will really help understand your local population and their access to services. So very quickly, a lot of you have signed up for this because it's talking about sustainability and transformation plans. And we all know that the NHS outlined a new approach to help ensure health and care services are built around the needs of local populations. So it's the place-based commissioning, the place-based planning, but doing it on a much larger scale than we have done in order to achieve some efficiencies, economies of scale, and to be more sustainable going forward in the future. So it's through that lens, I guess, that we're asking you to have a look at some of the data that you see here. So there's lots of functionality about how you can look at an individual and interrogate this data, but the opportunities of using this across a sustainability and transformation plan footprint is huge, and it's through that lens, I guess, that we will be asking you to take a look at that today. So now I'm going to hand over to Matt, who's going to take you through a demonstration of the tool and what you would get on your laptop if you had this tool or access this tool. He will show you how it's used. So I'll just see if I can hand this back to Matt. Of course, this worked in the practice. Here we go. Hopefully, Matt, you should have this now. Perfect.
Hello everyone. Now you should hopefully see my screen. I'll give it just a moment just to let everyone else catch up. So as Ali says, my name is Matt and I'm a business analyst here at Pi. So I'm going to show you some of the functionality of the tool. So what you're going to see is actually what the user community sees. So these dashboards are actually what our users receive from us on a monthly basis, and I'll show you kind of how they use them as well. So this specific demonstration that I'm going to show you just covers people aged over 85 within a specific CCG. And what we're looking at straight away is a demographic analysis. And what you can see just on the top left are our integrated data sets. So you can actually see here that we've got 111, A&E, ambulance, community data, inpatient, outpatient, social care assessments, and social care packages. So actually we receive all of those different data sets and we can integrate them together to give us a holistic view. And actually in certain areas we also receive GP data and we can integrate that in as well. And what we're looking at is for this cohort of individuals, actually we're looking at about 8,500 individuals here. It's got their combined cost across health and social care between this time period. Got some information on their ethnicity, where they're located, their services, all the different services that these individuals have used, and we've also got a breakdown of their long-term conditions here. Cool. So what we can do is we can select social care packages, like so, and now it just gives us a breakdown of our social care demographic. So actually what we've got is 1,688 people receiving social care services within this cohort of individuals in this locality. And again, we've got their ethnicity breakdown, their long-term condition breakdown, and also the breakdown of services. So you've got all the services that you'd expect to see there. You've got reablement, home care, residential, adaptations, direct payments, nursing, and it's got the number of people using each of these services. So a lot of what we're doing is about breaking things down into specific cohorts of individuals and then doing some analysis on those cohorts of individuals. So at the moment our cohort is an over 85 cohort for a specific locality, but again we can just look at a social care cohort, and I'll talk a little bit later about some of the other cohort breakdowns that we also have. So I think this dashboard here really very nice in showing you how our tool works. So actually what we're looking at here is care pathways for an individual. So what I'm going to show you is we start off at a really granular level, at individual episode level, and then we aggregate it all up so we can look at a system-wide level. So what I'm going to do, across the top here, we've got a number of individuals. Each bar is an individual, and at the moment they've just got an arbitrary risk score applied to them. We do add some more complex risk scores, and I'm going to show you some of those later on. So we've selected this one high-risk individual. We've got a bit of information about this individual. That is a pseudonymized NHS number. So so we don't have those NHS numbers out in the clear. We've got age, gender, their ethnicity, the cost for this specific individual, and their anonymised practice as well. And what you can see here is actually the care pathway for this one person. So if I stretch that out just to give a slightly better view of it, now what we can see is the service usage for this one particular individual. You can see they've had reablement services, emergency admissions, contact assessments, they've ambulance conveyed and non-conveyed, other social care services, A&E, and they've also called 111. And actually for this one individual we can track and see what's actually happened to them. So we can see they've had an emergency admission here, they've had another emergency admission, they've had a period of reablement, then they've had another emergency admission, so you may say actually that period of reablement didn't work in the way it's supposed to. They've had 2 more emergency admissions within 2 days here, another period of reablement, and even more emergency admissions mixed in with 111 calls and actually turning up to A&E as well. And you can say actually for this one particular individual, should some intervention be put in place? But I think what you're more interested in today is actually looking at data at a slightly higher level. But I need to show you that at the granular level just so you can understand what's going on. So finally, if I just select one particular record, that gives us some information on that one particular emergency admission. So we've got who they are, age, gender, ethnicity, their long-term conditions, the number of long-term conditions, but information about the particular activity. So we know it was an emergency admission in geriatric medicine. We've got when it was, the start date, end date, who provided it, the cost, the diagnosis. And what we can do is we can actually look at things like the services that they've used across time. So we've got things like the previous 3 events. That's what happened to this individual prior to this emergency admission. We've got what happened to them 1 day before, 1 month before, 3 months before. And we can also look to see what's happened to this individual 1 week after, 1 month after, 3 months after. So what we'll do is we'll show you how we use that information at a more aggregated level to give us more of a holistic view of our cohort of individuals. So what we're looking at now is in the middle we've got activities. So that is just a number of different services for our cohort. And what we've got here is what's happened to this cohort of people the previous month, the previous 3 months, the next month, and again in the next 3 months. And at the moment actually it doesn't show too much usable information, but actually if I drill down into one specific service, and the service I know that everybody is interested in at the moment is the reablement service. So we'll drill right down to the reablement service, and we can see a number of people. Try to turn off the filter. You can see a number of people, 802 people here using the reablement service. We've got their age and gender demographic, and we've also got the long-term conditions of the individuals that are using this reablement service within the time period 2015 that we can see at the top. And what we can look to see is, of this 802 people, what was happening to the people in the previous month and the previous 3 months. And actually, as expected, we've got people having high numbers of emergency admissions and A&E. And as expected, as it's usually a prerequisite for people before they go into reablement service. But more interestingly is actually that we can start to look and see what's happening to these people after the reablement service. So we can look and see what's happened to these people within the next month. Have they been readmitted? And actually we can see of this 802 people, only 86 of them have actually had an emergency admission post-reablement service. Slightly higher number turning up in A&E, but only 86 of 802 people having emergency admission. And then if we look at the next 3 months, so that's a cumulative next 3 months, we can see that 151 people are having emergency admission. And actually those numbers are quite low. Sometimes what we can find though is when we look at things like 4 months later, the numbers of emergency admissions start to rise quite significantly, as these reablement services may only run for 30 days, potentially 90 days, and actually the effect that they're having actually stops at that point. So I'm going to show you a little bit more functionality of the tool, the tool that the users have. And what we can do is we can break this down by a specific long-term condition. So if we're actually interested in individuals with dementia, what I can actually do is select dementia here on the right hand side. And that filters it down, and actually we can now look at people with dementia and their reablement pathway for people with dementia. Because we know that people with different long-term conditions have slightly different pathways. I think it's very important for us to understand the pathways for different cohorts of people and people with different long-term conditions also. So I'm going to keep with the theme of pathways and before and afters, but we're going to look at it at a slightly different angle. This is actually more of a whole system level, and there are a lot more costs involved here. So it looks slightly complex to start with, but I'm going to run through it and explain exactly what it is that we're looking at. So what we're looking at is we're looking at what has happened across the system to the cohort of individuals that have had a fall. So what we've got here is point 0. So point 0 is the point of a fall. And we've got -1 month, -2 months, 3 months, all the way to 12 months. And we've got what is actually happening to these individuals prior to the fall, in the 12 months prior to the fall. And we've also got 1 to 12, and that's what's happening to these individuals after the fall. At the top here, we've got the costs. So this is the social care costs. Below that, the social care new activity. Below that again, we've got the acute care costs and the acute care new activity. And on the left-hand side here, we've actually got the costs broken down by GP practice. Okay, so back to this. We are looking at this cohort that's had a fall here at point 0. And as expected, we've got a large number of emergency admissions and a high cost emergency admissions as well. So these people have had a fall, they've gone into hospital, they may have broken a bone, they may have needed some sort of inpatient stay because of the fall. And that's what's expected. We know that when someone has a fall, there will be an expense to acute care. But actually, what's kind of more interesting to look at here is actually what's happening to social care. So, top here, we can see reasonably low levels of social care activity in this cohort of individuals. And we've got the point of the fall. A lot of these individuals are in hospitals, so actually we see social care costs fall significantly. But then, moving on from there, we've actually got high cost residential packages, home care, nursing packages for this cohort of individuals that have fallen. And actually we can see the cost to the entire system for a fall. And actually we can start to say, should we be putting an intervention in place earlier to try and avoid falls? And what we've done with some of our users, some of our client base, is actually to use this same type of analysis, and they put an intervention in place and actually said, looked at this same graph before the intervention was in place and after the intervention was in place, actually looked to see how the costs vary. So obviously if the intervention was in social care, we will see a rise in the social care costs over here. But actually there'll be less falls, and actually the costs post a fall should not be quite so high for the same cohort of individuals. So this is just an example just for falls, but actually we can do the same sort of analysis for any event. So we can look at a specific service. So we could look at something like, as we looked at before, the reablement service. So we can say what actually happens to people before and after a reablement service. We can take it to the acute side and actually say what happens to people before and after an emergency admission. What happens to people before and after a specific emergency admission. So it's not just looking at falls. Actually we can look at any event and get a whole system view of the effect that that event has on the health and social care environment. So I'm going to take us back to our original file. We're going to look at something at a slightly different angle, but we're still going to look at emergency admissions. But this, what I'm going to show you now, actually shows the link between health and social care very, very well. And what we're looking at is emergency admissions from residential and nursing homes. So at PI, we receive the data for health and for social care. So we can actually map across the two to see whether or not people are in a residential home at the point they're having an emergency admission. And actually, if you've just got that health data, you don't get that information, because the way health data is coded is actually within the health data it will say someone's come from their usual place of residence, and that could be their home, that could be a nursing home. Unless we start to use postcodes, which then can become slightly sketchy. We don't know whether or not this admission has come from a residential home. Because we've got that information, we can actually look and see these people are having admissions from residential homes. So back to the graph, back to the dashboard. On the left-hand side, we've got, these are all pseudonymized names of homes. We've got the number of people that have been admitted from these homes, the number of admissions for these people, and we've also got the total cost of these admissions. And if you see down here on the bottom right, we've got the primary diagnosis. So that's the reasons that these people are being admitted. And top here, we've just got a graph. Actually, it looks like York. It's actually a pseudonymized data set. And if it was your locality, you'd get a map of your locality and where these people are based. So the way this dashboard is actually used is, one, it's used to look to see how many people are being admitted from care homes, what are our problem homes, why are these people being admitted from these homes. So when we start to look at the primary diagnosis for these homes, at the top here you've got things like pneumonia, UTIs, again pneumonia, and fractures again. And what we can say is people probably shouldn't be being admitted for pneumonia, UTIs, and fractures when they're in a care home. You'd assume that pneumonia can be treated in the care home, a UTI I know can be treated in the care home, and a fracture most often comes from a fall. And I think it actually puts us in a great position to actually say these homes need our support. And actually if we support these homes, put more interventions in place within the homes, it can actually reduce the numbers of admissions from care homes. And this is quite a low-level dashboard, but actually we do some higher-level dashboards that just give how many people are being admitted from a care home this month and which homes are they coming from. And when we start to do comparisons month on month, we can say actually these homes that have had the support, these homes that have had some sort of intervention, are the numbers of emergency admissions for these homes actually falling. So as you can see, a lot of what we're doing is around either pathways, admissions, where people are coming from, and actually where people are going to as well. So keeping on the emergency admission route, what we're looking at the moment is what's happening to people prior to emergency admissions. So actually, where are these people coming from? So you can see here we've got a number of pathways on the left-hand side. We've got the number of people following these pathways in the middle here. We've got the number of times these pathways have been followed on the left, and on the right we've got the total costs for the admissions at the end of these pathways. And what we can actually see from this diagram is the most common pathway that's being followed is actually the outpatient, 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 A&E, inpatient emergency admission pathway. And that's very interesting because these people are known to the system. We actually know who these people are because they're turning up and having regular outpatient appointments. And then they're turning up in A&E and then having an inpatient emergency admission. And actually I did a piece of analysis earlier last week in Leicestershire looking at a specific cohort of people that were following this pathway. And actually something that we found was these outpatient appointments were in ophthalmology. And actually these people have having eye problems and then they're having emergency admissions. And the emergency admissions were not for their eye problems. They may have been for falls. But actually you can start to put an intervention in place to say these people are having these ophthalmology appointments, we know where they are, we know who they are, let's put an intervention in place to try and stop them turning up and having expensive inpatient emergency admissions. And again, we can break this all down by long-term conditions and specific cohorts of individuals. So if I want to break this down by a long-term condition, what I'm going to do, if I pick hypertension, for example, now we're just looking at the pathways for our hypertension individuals, and as expected, the diagnosis changes. One of the highest diagnoses for our hypertension individuals is actually heart failure. Okay, so moving on. Now we're just going to look again at admissions, but actually we're going to look at readmissions, so people that have gone into hospital and then within 30 days they've gone to hospital again. And not only are we just looking at readmissions, we're actually looking at readmissions where they've had a reablement service prior to admission. So these people had gone into hospital, been admitted, they've had their hospital stay, then they've had a reablement service, but then they've still gone into hospital after the reablement service. And what we can see here is we've got 138 people here. Top graph here is people being readmitted for a different reason, and the bottom line here, the brown line, is people that have been readmitted for the same reason. So they've gone into hospital for a reason, they've had a reablement service, and then they've been readmitted for exactly the same reason. At the bottom we've got the reasons for these readmissions. And actually, you see right in the middle there, one of the main reasons for this is repeated falls. And you say, should some sort of intervention be put in place to stop these people falling? We know these people have fallen, they've had a reablement service essentially to get them back on their feet, and then they're falling again. Actually, maybe we should look at the reablement service and say, is it doing what we expect? Should we be doing more for these falls individuals? So, that is the end of a kind of standard demo. This is what our users receive. But I'm going to move on and talk about something slightly different, and that's actually predictive risk. And let's give you a demonstration of our predictive risk stratification tool. So, we've been working on predictive risk for quite some time, forecasting changes in patients. And changes can be predicted from multiple aspects, such as the health needs, the social care need, different needs through all the data sets that we receive. And what we do is we develop bespoke risk models using many, many different statistical methods. This method that I'm showing you at the moment is actually going to be using multiple decision tree algorithms. And essentially what we do is we look at the past data and we look at the variables for individuals that have had emergency admissions or a high health or social care need, and look at the variables for those individuals, and then we look at what's going on now. And we use similar variables from today to say, is our cohort of people today at risk, and who within our cohort of individuals is at risk today. So as I said, these models are generated on a locality by locality basis, so each one is slightly different, but actually the accuracy is all quite very similar, and actually we've had in some areas around 80 to 85% predictive accuracy. So let's just show you a little bit of what's going on in our predictive risk stratification. So if I just move us on one more, I think one of the best things about our risk stratification tool is that we have multiple risk models. So not only is it a standard risk model in which we can predict emergency admissions, actually we can look at A&E, we can look at outpatient services, we look at specific community-based services, and we can also look at the risk of social care services. I know this is very, very interesting, the social care space, to actually have a social care risk stratification model. So I'm going to explain now what it is exactly that we're looking at. So here we've got some individual identifiers, pseudonymized individual identifiers. We've got a risk score. So this is just a list of individuals' risk scores that we've predicted for those individuals. We've got their age, gender, long-term conditions, the services that we know they've used in the last 12 months, and also the services that we believe that they're going to use in the next 12 months. Actually, if we look over here on the right-hand side, we can actually change our risk model. So, and actually we find that the people with high need for health services is not always the same individuals that we predict have high need for social care services. So if I flip this over and actually look at those people with social care needs, it's changed. We've actually got a slightly different cohort of individuals, which can be very interesting for people, social care suppliers, or also for the councils. And we've got here different people. Actually, these people don't have any long-term conditions, but we still predict that they're going to need some social care services. And another quite interesting feature here is to look at the risk model overlap. So here we've got people that are at risk of A&E, emergency admission, and also social care. So you see in the middle of this graph here, these are, I would say, some of our highest risk individuals, because these specific individuals are actually going to need multiple services within the next 12 months. I'm just going to move on to our final graph. So this again was at a granular level, and I'm going to take us from that granular level and then move us up to an aggregated level. So the graph here is very, very simple, similar to our aggregated care pathways that I showed you earlier, but it's actually predictive care pathways. So instead of having a service in the middle here, actually in the middle here is a point in time, and for this demonstration actually that point of time is now. And what we can do is we can look at the services that these people have used in the last 12 months and the previous 12 months from now, and we've got the services that we predict that they're going to need in the next 12 months. And we can actually look at things like readmissions, or people that have had a high number of inpatient emergency admissions. So if we look at our inpatient emergency admission cohort, we can look and say, so these people have had an inpatient emergency admission in the last 12 months, and we actually predict that this number here is going to have another inpatient emergency admission in the next 12 months. This can also be broken down, as I said earlier, by things like long-term conditions. So if I just hit a long-term condition here, and if I want to look at mental health individuals, so now we've just broken that down by mental health individuals. So we can actually look at the predicted services that we believe people are going to need in the next 12 months for this mental health cohort. And as I said earlier, we do a lot around specific cohorts. So we can do things like a mental health cohort, a learning disabilities cohort, physical disabilities cohort. We can create cohorts essentially on anything that people really need to do analysis on. Okay, that is the end of my demo. I am going to pass you back over to Alison.
Thanks, Matt. I'll just wait until I get that across. Fabulous. Just checking you can see my screen. Is that yes, Matt?
That's great, Alison. Thank you.
Fab. Thank you. Right, okay, so I've got this screen up here at the moment just to show you a little bit about the range of organizations and systems that are using this tool. And it's really just to highlight that they're using it for very different projects, but it's the same tool, and quite often it's the same types of data. So it's your secondary use data, it's your ambulance, it's your 111, it's the social care data, it's the same data that comes through, and different people are using the tool with the same data to look at different things. So I guess what I'm saying is if you had one organization that did all of these projects just using that one tool, you'd be getting incredible value. And that's what some of the systems that we're working with now, and I think Leicestershire is a very good example at the moment in terms of the various different work streams that they're developing. So as you mentioned, Matt, talking about mental health, talking about learning disabilities, setting up work streams, but using the same information, but looking at it differently. Having different dashboards to support what is the cohort of people they're looking to try and improve the outcomes for. So if I take, for example, just a very quick one around mental health and how using it in this way is really changing decisions around longer-term investment in local populations around mental health services. So some data analysis has identified in an area that there are a lot of people with mental health conditions going to A&E. And one of the investment improvements that was decided was that the demand made of mental health liaison was such that there needed to be more investment in the mental health liaison service. But what we did by looking at the pathways of people going to A&E, where they were going before they arrived and what happened to them afterwards, times of day, and looking at that whole journey, we saw that there were opportunities where these same people had potentially already gone to the GP that day, had tried to access other services that day, and are ending up at a particular time in the evening when there were other services not available, and mental health liaison service was less. Instead of thinking about investing in mental health liaison services at later times at night, some systems have now said, well, do you know, we could look at investing in something a bit further down the pathway. What about looking at crisis cafes? What about looking at things that in primary care, where we might skill up primary care teams to have mental health support services, so that when these individuals do go to primary care, to their GPs, they get what they need a lot quicker. So that it is really looking at it in a pathway view, looking at it over time and what times people are accessing it, is really helping to change the way people are thinking about where you would invest your services in the long term, and it is driving much more around preventative services. So that's just kind of one example of how we would say this is really helping in terms of system-wide. I'd just like to take you to finally a little bit about how we work, and I did mention already around it being quite quick. So 6 weeks. So that 6 weeks is when we get your data. So your SUS data, secondary use data, your social care data, your whatever the data flows is that we get from that time to the time when you view it in the way that you want to view it. So you've seen today. So you might want an urgent care dashboard, you might want a dashboard around residential homes, you might want something around your mental health cohort or your falls cohort. That takes 6 weeks. The time before that is around contract signing or data sharing agreements. So everyone has to agree that they want to share data in this way. And I will stress this is pseudonymized data. I've noticed a spelling mistake on my chart there, but so you'll have to forgive me. But it's pseudonymized data. And in order to do that, we sign the contracts, and it's as fast as your system wants that to happen. So data sharing agreements, we've done these now for quite some time, and some of the ones that we've used in other systems are fit for purpose in other systems. So developing them just needs a check through with legal and governance areas to check that that's fit for purpose in your area. And then once they're all signed by those parties that you're happy to share pseudonymized data, and we agree how that data is going to be pseudonymized, once we get that data through, it is only 6 weeks. So it's just to highlight that to you. So in terms of next steps, what I've put on here is a contact detail for myself. We will follow up with you. We will send you an email with our contact details, and just to ask for some feedback on what you've seen today, if you've got any questions. We've got a question here around cost that's been submitted by somebody online, and that does vary, and I know I'm speaking for the company, but it is a very reasonable, a lot lower cost than you would imagine that it would be for different areas. So, and because it's spread across systems, because it's something that's worked across multiple organisations, cost is shared. So per organisation, it can be quite low indeed. So I couldn't say it's a very standard cost, but I'm more than happy to talk to people if you want to talk to me about it afterwards. Matt, I just want to check, have you got any other questions that has come through at all? I just want to confirm I haven't seen anything else come through.
Yes, we've just had one other question just around minimum data sets, and what's the minimum number of data sets that we can use. And we usually like to say the minimum is actually just that SUS, that secondary use services data set, and the social care data set. So in the demonstration that I showed earlier, we had a number of other data sets, 111, ambulance, we have out of hours, community care, but actually we can do it with just the 2 data sets, health and social care.
Great, thank you. If there isn't any other questions, please use your chat now if you've got any last burning questions, but we will, as I say, we'll follow up with emails to you all who've joined the call and facilitate you contacting us and asking any other questions you've had from this webinar. And I hope you've enjoyed it. Thank you very much.